All right, it's that time of week. We've got, what have we got today? 6 studies on the docket, but a lot of them overlap again. And some of these really just are updates. So we're going to start with this one. Elevated glycated hemoglobin affects the Achilles tendon properties and walking capacity in healthy people without a diagnosis of diabetes. So what is that saying? Well, when we take a look to test for diabetes, one of the most common tests out there is looking for something called the hemoglobin A1C. Now, there are others that we like to do. And in the office, we've got urinalysis dipsticks where we just see if there's any glucose sugar in the urine, because that usually indicates that there's a spike that we can associate with the blood levels. There's the hemoglobin A1C, which is a longer form, basically seeing how approximately elevated your blood sugar has been within the last 3 months approximately. And it's not bad. It's well utilized as far as lab tests go. But another one that we are starting to add in is fasting insulin, because like this one shows that these people do not have a diagnosis of diabetes. That means their blood sugar and insulin are generally within the normal ranges, although maybe not insulin. They may actually have the early signs of insulin resistance with this one. But I'm getting off tangent. Basically, what they're seeing in this test is when they took participants below the diabetic threshold, when they tested hemoglobin A1C, because they have lab values where it's normal, pre, and then full-blown diabetic. Basically, anybody who's not in that diabetic range, did it actually impact one of the largest tendons in our body, the Achilles tendon? And they found was yes, yes, it did. The reason they asked this is because diabetes, when you have it, full blown, it does have systemic effects on your entire system, chemically, mechanically, musculoskeletally. And so they basically thought, what if even in the process of getting to diabetes, we're already starting to see some of these changes in this case, tendon integrity and capacity. And I kind of like that idea because it lets us get ahead of the curve and start educating our patients on a more proactive approach rather than waiting till diabetes. Like, well, I don't have diabetes yet. It's like, well, no, but change is already happening. And that's why I love studies like this. So what did they do? They took 158 people, matched them for gender, age, physical activity level, BMI, and divided them into 2 cohorts based on that lab test, that hemoglobin A1C level. They had a normal value and an altered value. They performed walking trials to evaluate the kinematics, or how well the system that they were measuring was moving, during walling at the self-selected speed, and quantitative MRI scans of the Achilles tendon to figure out what is going on within the actual tendon. And let's see here. They exhibited slower self-selected walking speed, shorter stride length, and they basically were able to, between the kinematic tests and the MRI tests, to figure out, or suggest anyway, that a non-pathological increase in hemoglobin A1C is able to negatively affect the Achilles tendon collagen quality and walking capacity in healthy people. So these aren't things that we would see. It's like a lot of other diseases. For example, cardiovascular disease. Very often we don't see the physical signs, the obvious signs, until you're well into the disease. I think of atherosclerosis and clotting of the arteries. You don't typically have angina or chest pain until you have arteries that are like 80% clogged. Same thing here. We're starting to see changes in a pre-diabetic state, or at least an altered hemoglobin A1C state, in your Achilles tendon collagen quality and walking capacity. So you're already having these alterations as we're getting closer to the full-blown disease itself. To me, this just emphasizes a reason to be very proactive about your health. Just because you don't have the number that says, oh, I'm diabetic, I'm just pre-diabetic. Don't brush it off. The fact that you're pre-diabetic means that things are already changing. You have an onset of insulin resistance. Your chemical morphology, your chemical chemical kinematics. It's not pathopharmacology. It's basically the chemical physiology within your system is already changing, and we're now starting to see altered kinematics and musculoskeletal signs in these early onset studies. So I love this study to give us a little bit of canary in the coal mine scenario. That ties into this study here, associations between insulin resistance and low back pain. Can you guess where this one's probably going to go, or what this result is going to be? They basically said insulin resistance is associated with an increased risk of low back pain. The parameters that they measured, which was insulin resistance and weight, BMI, etc., all these parameters that are associated with diabetes, essentially a metabolic syndrome, whether you agree that there's a syndrome or not. People who have this metabolic syndrome, including insulin resistance, had each one of these markers increase the likelihood that they had low back pain. So we have from the first study, Achilles tendon morphology changing, your walking pattern is changing. Now we're seeing that this insulin resistance is also essentially a risk factor for developing low back pain. And I have my assumptions as to why that is. It's a lot of that natural chemical change that your body's essentially trying to fight off. And if we have a finite number of resources that your brain, body, etc., is allocating to maintain its level of balance, its homeostasis, throwing something in there or having the body being forced to change how it reacts to things like blood sugar is going to shunt some level of resource to deal with that natural change. And that may leave us predisposed to developing pain because we don't have the capacity to deal with a lot of the activities of daily living that it's in the name, activities of daily living. We have to do them to live. So it's pretty neat, again, to see that these two studies came across my docket in the past 2 weeks and they tie together. But yeah, the relationship between insulin resistance and low back pain is stable and in most stratified populations. It's there, we can measure it, and now we can start to assume, which again, we know what that means. It makes out of you and me, but it's something that if we check it or catch it in office, just like some other things, we can tell them that, hey, there's an increased risk that we are going to develop low back pain. So if you have an acute episode, get it taken care of sooner so it doesn't turn chronic. If you start to feel like a flare-up might happen, get ahead of it. I'd rather we be proactive than reactive. And this is something where once we get out of the acute pain phase, I would start to see if there's a way that we can, through lifestyle management, nutritional therapy, attack this insulin resistance. And if not, then incorporate other providers to co-manage it so that people no longer have insulin resistance, because we already see that there are changes happening in the body that we want to get ahead of. So we have a lot on low back pain for this one, or this series of studies. The next one dealing with low back pain is the lumbar multifidus dysfunction and chronic low back pain. So the multifidus muscle is one of the deeper low back muscles, and it essentially interconnects, not right next to each other vertebra, but essentially it skips one or two and it kind of fans out in an angle like the what is it on a boat? The rigging on an actual sailboat. It kind of reaches out and has these fun little angles. I digress. What this one did was they wanted to measure the quality of the muscle itself in terms of low back pain. And I've seen studies like this when it comes to like the quadratus lumborum. So a similar area, just more on the surface level. As far as muscles, this one's measuring a deeper muscle. But the results of these two studies that I've seen now are the same. And it's not fun because I want to talk about specifically this and then a little bit of this. So I'll start with the atrophy first. So atrophy, if you don't know, that's when your tissue shrinks, whether it is from disuse or injury, etc. So non-specific chronic low back pain is correlated with multifidus atrophy. And we can talk about chicken and the egg scenarios. A lot of the times it's incident of pain first, reduces a person's ability to move or want to move. They develop kinesiophobia, and you essentially lock up, like you reduce your range of motion naturally, which means you're not going to use the muscle as much. So it's going to shrink the muscle because it's not as important uh, at this stage in your life. The problem with that is twofold. One, the multifidus muscle is very, very important because these deeper muscles and these smaller muscles are typically not associated with moving my back physically, but sensing where it's at in space. So if my back has a reduced ability to kind of figure out where I'm at as fast as it used to, this may be where people develop flare-ups for relatively benign scenarios. Like, oh, I just went to bend over and pick this up, and then my back locked up, or I threw it out. I've heard a lot of different um, descriptions of it. And people often wonder why. And while we can't give them a definitive answer, there are some people that this may be a factor in the sense that your body didn't have its communication network operating at full capacity. So there was a miscommunication between the brain and the low back, and now there's an argument, and now we're dealing with a flare up or an injury, sprain, strain, something in the system. So atrophy isn't good, especially for a sensory muscle. The really crummy thing is this fatty infiltration. It's exactly as it sounds. So within the actual muscle itself. So if we want to keep it really, really simple, pretend that you have a piece of cable. You cut that cable off, and now you're looking at it right on front. You see all the little individual cables that are wound together to form the bigger cable, right? So what happens is we have fat that weaves in between the actual individual cables. And for you people who barbecue, it's like, oh, marbling, that's fantastic. Well, for cooking meat, yeah, because you cook it and it dissolves and you get more flavor. But for humans and function, it's not good. The reason being is that fatty infiltration, the fat itself is something called a non-contractile tissue. And we are putting it in a contractile system. What does that mean? Muscles, even these ones that have to sense where you're at in space, have to contract like a spring. Basically, do they spring back? Do they let loose? It tells the system how much tension is there, and that information gets fed to the brain. And it is a factor for how, if you need to pull hard and strong to run, grab something, how much of individual muscle fibers are there to do the job. And if we're replacing those muscle fibers, which can contract, which can stretch, which can do all the things we need them to do, and we replace them with fat that is inert, it's just there, now you quite literally do not have as much capacity as you would have if you had a normal, healthy muscle tissue. So it's terrible because you can't really exercise the fatty infiltrate out. You at least, okay, let me rephrase. You can't, as far as I know, as of this date, May 30th, 2025, you cannot exercise out this fatty infiltration. You can exercise the remaining tissue. So it is not a death knell. It is not a nail in the coffin. We can still do therapeutic exercise and rehab to actually reverse the atrophy and improve the quality of the remaining tissue. But I do not know at this point if the fat will naturally recede on its own. That is something that I would have to do more digging clinically. And I don't know if there's actually that much research out there yet to say one way or the other. I just know as of right now, clinically speaking, I would have this conversation with the patient where I want to improve the quality of the remaining tissue, and that we have to deal with the fact that there's fatty infiltration, and that might reduce the capacity, that might prolong the recovery, and it might require a multi-pronged approach from multiple providers to make sure that this person gets the best chance they've got to reduce their incidence of chronic low back pain. So we do not want to see fatty infiltration because it's not a quick process. It takes time, and this tells us some things about what your system has been through and for how long it's been going through it. So the earlier that we can intervene to reduce the odds of fatty infiltration happening, the better. So movement is medicine. We shouldn't just sit around like I'm currently doing and let these things just happen to us. We should be, again, so it's probably going to be the theme of the rest of the talk, proactive about these things. So let's see here. Is there anything else about this study that I wanted to talk about? No, they just talk about different potential interventions, which we've talked about in other studies before. So moving on. This one's kind of saying a similar thing. This one's from radiology, the morphology and composition of paravertebral muscles. So very, very close to the multifidus, rather than this, widespread rigging. This is usually going right along the spine and interconnecting each adjacent vertebra. This one is a systematic review and meta-analysis just to see what is the general quality of the muscle itself, and does that correlate with low back pain. So they took a look at PubMed, did a whole bunch of searches. So their searches included 17 studies looking at the paraspinal muscles in patients with low back pain. And what they found was a significant reduction in the cross-sectional area of the multifidus muscle. So we have that atrophy accompanied by increased fat infiltration of the multifidus, just like the last study, and the erector spinae muscles. So it's not isolated. So now I have studies for in the QL. The previous one, it's in the multifidus, and it's no surprise that the muscles right next to the multifidus, the erector spinae, also are getting fatty infiltration. They didn't find that much in the psoas major or the quadratus lumborum. So even though I said that there is a study in there, in their review, they didn't see differences in the cross-sectional area atrophy, I should say. So let me walk that a step back. They didn't observe a reduction in the cross-sectional area of the erector spinae, psoas major, and quadratus lumborum, which I find interesting in the erector spinae since it's getting fatty infiltration, but they didn't notice cross-sectional area reduction yet. So what does that mean? Well, it's worth a future investigation to ask that question because they only had 17 studies. Is there a study specifically that is asking about it? If not, then they would have to develop it. So just because it doesn't correlate as far as the fatty infiltration of the erector spinae doesn't automatically mean that we just say it's definitive. Nope, this is one thing that says, oh, we see this correlation. We now either have to dig through other research to figure that out and or develop new research to answer that question. Same thing with the quadratus lumborum, as I've seen studies where the fatty infiltration is there, but this one is, they don't see a reduction in the actual muscle size, the functional cross-sectional area. And they didn't see fat infiltration in the psoas major, which is neat. Thankfully, a muscle is spared. So their conclusion to all of this was that the morphology and composition of these muscles are altered in individuals with low back pain, which they characterize with reduced multifidus muscles, particularly at the L4, L5 muscle, increased fatty infiltration compared to healthy controls, and a slight increase in fatty infiltration in the erector spinae muscles of low back pain patients. So your body changes and adapts around what it's actively going through. Some of that adaptation is inputting fat into that system where it shouldn't be, but that's what your body does, and it's something that we need to get ahead of. All right, last two studies. Assessment of the piriformis muscle thickening in patients with sciatica. So this one was rather interesting. It's just a paragraph, but what they found was on the side of sciatica. So sciatica being low back pain with radiation down the leg a fair ways. The side that the radiation went down, the piriformis muscle, so a muscle that essentially, if, let's see if I can do this right here. Let's do it this way. So if this is the sciatic nerve coming off, and if, see if I can get this in screen here. So if we have spine and then we have, pretend that this is a leg, the big nerve of the leg coming down, my finger knuckle right here would be essentially the piriformis muscle. It's in your glute area. It goes from the sacrum into the hip, and oftentimes it's blamed for a lot of hip pain and or some symptoms of sciatica. Piriformis syndrome has been out there, which again, there's some argument of, is it there? If it is it overdiagnosed, underdiagnosed, etc.? Not a discussion for here. What it did find though was that, again, the side that the radiation went down, the side you had sciatica on, that muscle was thicker, notably thicker in this study. And there's some assumptions as to why. If you're trying to guard the system, protect the system, because that's the side that's in pain, the muscle will naturally want to contract and be thicker. Another one that they recommend, or not recommend, suggest, and I happen to agree with, is the fact that there's going to be general inflammation in that side because your body's going through this inflammatory process during sciatica. So that would correlate, or that would cause the imaging itself to show a thickened or enlarged piriformis muscle. So it's an interesting sign that we have to figure out, does it clinically correlate? But it may explain some of the symptoms in some of the patients, especially if they're fidgety and they don't like to sit on that side. Whether or not that is the source of the sciatica itself, it is a factor that maybe we take into account that, all right, that side piriformis muscle is going to be thicker, so we may not have as much room, and we may, for lack of a better word, piss it off sooner should we go too aggressive with manual therapy. So we should focus on light, not necessarily lighter, a different form of manual therapy that addresses that inflammation, taking into account the process happening there. The fact that it is thicker, so when we palpate it, we shouldn't be surprised if we palpate it being thicker and larger and mistake it for something else. And then just take care when treating these patients. And if they have symptoms of the piriformis being affected, don't just slap the label on, oh, it's piriformis syndrome, that's what I'm going to focus on. It's like, no, sciatica was on that side, the piriformis is thicker, and that's a symptom or a sign, not necessarily the source. So we can't just put the blinders on and blame the thing that is now screaming at you because it's enlarged, because it went through that inflammatory process, that's what you treat. You have to take it into account, but it shouldn't just be the only thing you do if patients complain about a lot of pain being right there when they sit down, and that's when they have sciatica. So pretty cool study in my opinion, just to see that. And last but not least, so we have lots of these studies that talk about low back pain. What do we do about it? Well, in this one, they had a meta-analysis to take a look at what interventions were used for low back pain, and they found that it depends on if you ask, is it about the pain or is it about the disability and function? Because they took a look at stabilization exercises versus, what was the other one that they classified here? It's in the results here. Core stability, that's it. So they look at spine stability versus core stability. One improved functional capacity a bit, or reduced disability more, and the other one reduced pain more. Why is that really important? Well, because I think a lot of these studies that ask these questions as far as stabilization exercises go lose the forest for the trees. They are so focused on going through a scripted exercise regime where you take, a patient from A, B, and C, and it has to be in that order all the time. So anybody with low back pain, you're going to be putting him through exercise A, exercise B, and exercise C, no matter what. And then if they look at this study going, oh, but if they have more disability, then I need to put them through exercise D, exercise E, and exercise F. is way too myopic, and it really puts too many blinders on looking at the system as a whole, the person as a whole, because pain is A, multifactorial, B, complex, C, very individual, and having a script of exact exercises to do all the time for the purpose of categorizing them as stability only, I think is going to not serve the greater population or future clinicians as a whole. Now, one caveat is when you're first starting out doing this, I'm not going to beget a student for wanting a system just to have when they're first working with patients who deal with this sort of stuff. It's debilitating. It's not fun. But we should be more principles based and not look at these as, core stability and low back stability. Treat them as a principle. So what is a common thing that these typically, what is a common approach that these systems usually incorporate as far as core stability and low back stability? They do a lot of low load exercises initially, and sometimes incorporate things like isometrics. And that's important because if we take that out and understand that that's the principle, starting off with a tolerable low load so that the system doesn't think that there's really danger associated with movement, which we can incorporate with isometrics to put a patient into a position that they don't currently have joint pain in and allow the muscles and systems to actually work through the problem, is a fantastic principle. But we don't want to just blanket label it as stabilization exercises or core exercises, because that will also then get people thinking that you can only do a plank for a core exercise. You can only do like a back extension for stabilization for the low back, or a bird dog for the low back. And that is not the case. As long as you get the system working around the problem, it doesn't matter the exercise. I mean, that's part of the fun about what we do here and taking so much time for our patients, is we can figure out, yeah, we have a few in the back pocket that we can pull out for pretty much anybody at any time for any reason, but it's adapting it to the individual based upon their wants, their needs, that truly make it rewarding, because it's not a prescripted, here's your one list of exercises that you're going to take home, read them off the sheet, do them, do just an isolated shoulder movement, no. The other reason that I don't like just categorizing these exercises as stability exercises is that's where people stay. So, and what do I mean by that? I've treated a lot of people where these types of exercises, these stability ones that they mention in here, they're a fantastic place to start when the system is putting a whole bunch of red flags there and you give them a safe initial contact point to get some movement in. But the problem is when they stay there, the system is now wanting more. It needs more to adapt. And if you don't give it more, you're not going to get past that point. The patient would have essentially done this. Okay, I'm in a whole bunch of pain. All right, let's start these exercises combined with whatever else the provider's doing. All right, pain's down a little bit. Good. Problem is, providers keep them on stabilization exercises. They stay here. They hit a plateau. They hit a barrier. And then you have people who aren't progressing for weeks, if not months, because you aren't pushing the system to where it needs to go to adapt. So that's why one more reason that I don't like just, hey, follow the core stability protocol, follow the low back protocol. No, start a person there because it's stable and safe for the system. But as soon as you're ready and as soon as the patient is willing, it's go, 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 go. So understand the principle behind it. Oh, yeah, I just gave them a safe intervention to do at a safe joint position, and the muscles and all the soft tissue got to work in a pain-free range of motion for right now when everything is screaming fire, fire, fire. All right. Hey, is that fire down a little bit? Yeah, my pain went from a 7 to about a 4. All right. Let's see if you're ready for the next step, because now it's not fire, fire, fire. You got some coals, you got some embers, so the system's still a little warm, but now you can hit it a bit harder so that you can get through the next step. And that's where I think studies like this, when a clinician looks at it, they need to understand that there's a principle behind it. Don't just follow the myopic protocol. These are fantastic in building your own principles and how to work with patients, but shouldn't be a hamstring where this is the only thing you do with a patient. So I've rambled long enough. Thanks for sticking with me this week. Look forward to next week. I have no idea what's going to pop across my feed. It was low back pain this week. Let's find out what next week's is.